Hello everyone, thank you for joining us for our pre-eclampsia placental growth factor testing webinar. We're very excited for you all to join us. My name's Louise Webster. I'm a clinical lecturer at King's College London and the co-chief investigator of the Parrot-2 trial, which is investigating repeat placental growth factor testing. The reason we've got the slide up at the moment is because we are keen to, for anyone who's interested to read more, to scan this QR code and go to our YouTube video, which tells you more about the journey that this testing has been through from our research group. But without too much further ado, we've got a fantastic panel lined up, and I'd like to hand over to Professor Andy Shennan, who is going to introduce us to the story of placental growth factor testing for pre-eclampsia.
Great, thank you very much, Louise. I'm just going to, I'm hoping you can see my slides, correct?
Yes.
Good. So in this 20 minutes or so, I want to just introduce the concept and a little bit of history behind placental growth factor. I think for many, many years, we've been struggling to improve our management around pre-eclampsia. And I think at last we have something that has come to our use, which could help. And what we hope to do during this forum is try and elucidate some of the thoughts about how we might use these tests. But as way of introduction, I'm just going to kind of go through the background. I'm not going to spend long on this because I'm sure you all appreciate the pathophysiology of preeclampsia. This very classic slide, which is shown again and again, just reminds us that this is probably a placentally derived condition, certainly the most plausible and popular theory. And the fact that we have a placental marker moving forward that is worthwhile and looks promising is no coincidence. Just going through the clinical scenario of preeclampsia and how it evolves, because this is really the crux of our management. We do know that placental implantation is a very early phenomenon, and probably the roots of this disease sort of take hold right at the beginning. Eventually, due to various pathophysiological consequences, women will present, and classically with high blood pressure and proteinuria or other clinical features of the disease. And not invariably, but quite often, symptoms will come on soon after these clinical signs manifest. But almost invariably, if you have the diagnosis right, which is not always the case, but there will be a crisis either in mother or baby that essentially requires urgent action, or a morbid or you know, a bad disaster will happen. And you can almost put your mortgage on the fact that this will happen within a 2-week time frame, if not less. And when it doesn't happen, it's usually because you've got the diagnosis wrong. So for most of the course of this disease, we know preeclampsia is there from a biochemical standpoint, but we simply have it's covert, and we just don't know it's coming. So essentially, it would be jolly nice to make use of some sign in these intervening period that would tell us it's coming. And the other key thing about preeclampsia management is we haven't got a magical cure to stop it, really. We have got some ways of ameliorating it, and there is some benefit of prophylaxis with aspirin and so on. But essentially, the hallmarks for saving lives and for making a difference is to identify those at risk and act in a timely manner while keeping them safe in the interim. And we've done incredibly well in the UK in achieving this. And therefore, it is recognition and action, particularly before somebody has a disaster, that has been key to safety. So the classical progression of preeclampsia from normal to crisis follows a pattern, and although this isn't uniform in every single case, and by definition the cases you miss are atypical and they become more common as you miss them, but nevertheless this classical scenario is quite commonplace. You go from normal pregnancy, you develop some pre-feature which may or may not be preeclampsia, and this is the problem, is that hypertension is quite common in people who don't go on and get preeclampsia, as are other features of the disease. So there are a lot of false positives with clinical features. So the arrow is there because this may be where we can use a biomarker from in early pregnancy. A biomarker may be able to identify those who you could target therapy to. But perhaps the most important area is this one, when people present with features which you're uncertain of, like hypertension. This is the clinical scenario is really difficult here, because we then potentially overmanage, admit people a lot. And it would be jolly nice to have a marker at this point before we go through that cascade of clinical events to say, look, this woman really doesn't need all these investigations and management and she can safely be sent home. Or yes, she is heading for a problem and we can target our efforts appropriately. What we don't know is if we target biomarkers at established disease. I think for PlGF, this is a bit of an unknown, and the jury is still out. The research is still being done about once you have established preeclampsia, then the biomarkers may not be as good. So it's really this intermediate group where we target them. Now, without going into too much detail, the biomarkers have been around for a while, and we know that the perhaps the most promising of these have been these angiogenic biomarkers. This is now an old slide, but there were literally hundreds of papers that have come out elucidating the fact that you have these changes, either a drop or an increase in these anti-angiogenic and angiogenic biomarkers, which fit with our knowledge of the pathophysiology of the disease. And actually, Lucy Chappell, when she collected data around about when the millennium started, she actually measured placental growth factor and showed very nicely and very clearly that from early on in pregnancy onwards, that if you went to get preeclampsia subsequently, you had pretty low levels of placental growth factor. So we knew about this 20 years ago. And it is interesting. This was longitudinal data taken on high-risk women, which was very powerful data. And we actually replicated it. This data was collected a couple of years later, and I found exactly the same thing. The former data was published in the American Journal. This data, interestingly, we couldn't find anyone who was interested in publishing it, although there was this clear longitudinal lower levels of PlGF in those destined to go on and get pregnant. And this was a longitudinal series. So Levine classically published this a little bit later, which was just cross-sectional data, but showed exactly the same thing, very low levels of PlGF, and the opposite for sound pathophysiological reasons, with an increase in soluble FLT. And by doing a ratio of these two, you can also get a good indicator of the disease process, which we're going to elucidate later. But I just want to share with you the sort of thoughts that we had at the time about what we would do. We knew there were a lot of angiogenic markers. There were a lot of other markers, literally hundreds, that were looking promising in both the management and prediction of preeclampsia. And so we decided to look at a number of them in our studies. And in fact, we picked 58 of the promising markers, and we looked at them together to see if they would identify at-risk situations in people who came in with suspected preeclampsia. Cut a long story short, there were about 6 that looked pretty good. PlGF was perhaps the best on its own, but what was interesting was when we added in the other biomarkers, including soluble FLT, we couldn't really make it any better. So the bottom line was a single test was pretty close to, all 6 tests, 6 of the most promising tests, even when you tortured the data to try and get the best prediction you can. So there was only a very small marginal benefit by doing that. And so we concluded that for very practical reasons, having a single test might be the way to go to market in terms of using this in clinical practice. And if you look at the ROC curves, this essentially shows you that they're all pretty superimposed, that PlGF alone gives you very good prediction of sensitivity and specificity for predicting people who have preeclampsia that requires delivery in the next couple of weeks when they present in that sort of critical time between about 24 and 35 weeks. When you compared PlGF alone with the sort of classical things we had been using to ascertain risk in suspected disease, like the blood pressure, the urate, the liver function, and even proteinuria, it was definitely better at telling us which women were going to require delivery in the coming days and which women were basically going to go months without a problem. I think one really important factor here was the actual assays used are slightly different between different companies. And so we know that placental growth factor has different isoforms, and each company has developed their own, which has different kind of preponderance to different types of isoforms. So it's very difficult to compare this. And as you can imagine, people were getting very confused when there was more than one company producing this. And some of the early data comparing the original ELIA platform with the Roche did show that PlGF alone was slightly different when comparing outcomes. And in fact, Roche had a different PlGF, but they used a ratio with soluble FLIT to come up with very comparable predictive values. So one of the things we did was we took our data from our clinical trials and we decided to compare in the COMPARE trial the three different assays that were available to us at the time. Two of them, Roche and Quidel, which you'll hear about later, are recommended by NICE as rule-out tests. I think one of the important things here is that you can't really compare these tests directly in the literature by sensitivity and specificity because they all have slightly different thresholds, and also they are different assays. So the very important question is one different from the other? And so depending on where they put the sensitivity, and also depending on the study done, because each study is also different, it'll have different risk status, different prevalence of the endpoint, different types of endpoints, which makes it really difficult to compare these trials. So we thought this was an important study to do, comparing the same samples, the same patients, all the different samples. And essentially, by using area under the curve, we got away from the problem of the companies having slightly different thresholds. And the bottom line is the PerkinElmer, the Quidel, the Roche assays were all identical with exactly the same ROC areas. You can see that there's slight differences in sensitivity even with the same endpoint, but this is purely driven by the threshold being slightly different. So the recommended thresholds are slightly different. And if you have a slightly better worse sensitivity, you have a better specificity. And obviously, if you want to favor rule out, you need to have a better sensitivity. So this kind of explains some of the confusion around these tests. And you have to be a little bit careful about comparing sensitivity, specificities, positive and negative predictive values for all the reasons I've said, different endpoints and different thresholds. So to kind of finish off then, we actually have come up with a table here, which has been published in the British Journal of Obs and Gynae, which has looked at the literature and taken a number of studies to show what is currently recommended as both a rule out, which is what NICE say, how NICE say we should be using these tests, but also a rule in. And we've also had to do our own research to come up with a novel rule in threshold for Delphia. So the first thing to say is they're all different. So a rule out for PerkinElmer will be different level as a rule out for the Quidel. But although these numbers are different, they are acting at the same levels. So these will be equivalent. And although they're slightly different from each other, they're pretty much telling you the same thing. And now Thermo Fisher also are on the market, and we haven't done a direct comparison with all the other tests, but it's very likely that this will be equally valuable. And for their rule out, they have a ratio over 55, which is thought to be equivalent to the ratio of 38. Just again, a health warning here, do not compare these sensitivities. Just because you see a sensitivity looking better for one commercial company versus another does not mean it's a better test, because the sensitivity will be driven by the endpoint that they happen to pick, the prevalence of the outcome, and it often is traded against the specificity. We know from the area under the curve that these are equivalent. And there are other details which we will hear about, such as how the tests are used, how much they cost, the volume of tests, when they're used. That will start to matter when it comes to whether you would favour one over the other. So you have here the suggested rule in, and again, so a ratio of over 5 for Roche is roughly equivalent to a level of under 12 for the Quidel sample, and you can see the other companies' ones here. So essentially we have a very good test that if you use it, doesn't really matter where it's from, it has roughly the same prediction abilities. So I'm very happy to take any questions now. We have been using this test. I think it's a really brilliant test in all sorts of scenarios. I think the other speakers will probably give some clues as to what those scenarios are. But I have to say, I think this is a real kind of advance in our ability to manage preeclampsia safely. And the rule out is phenomenal because it really does translate, we've shown, into cost effectiveness, apart from the obvious benefit to reassuring the mothers. So happy to take some questions, and I hope to come back and join you at the end with the panel. So Louise, do you want to field the questions?
Yes, sorry, my colleague Alice is just logging on to field the questions for us. But thank you, Andy, so much. That was fantastic.
So we just got a couple of questions in the chat. So one saying we use the PlGF test by Quidel, and the protocol is based on the paper in PLOS with 3 levels of care. And I often get asked whether in level 1 care, if the blood pressure does not require treatment, we defer the PET bloods if PlGF is more than 100. But is a growth scan still warranted? I mean,
essentially, if you have a level over 100, it's telling you you're normal. Okay. One of the beauties of these tests is they are telling you upstream about the pathophysiological process. So in other words, you can know with one simple test very quickly whether you have an underlying multisystem disorder or not. Therefore, if you don't have it, there really is no need to go on and investigate further. That's their huge advantage. A one-off test tells you whether you have to go down a pathway of this is preeclampsia and needs all the investigations, the sort of checking of all the organ systems, the baby, or it does not. And therefore, for all those reasons, it has its health, economic and clinical benefit. You say, oh, I'm not sure if this woman has a problem or not. Let's do a test. No, she doesn't. Go away. You save her a lot of time. You reassure her immediately. You don't have to admit. You do not have to do all those investigations. So in other words, over 10 is a rule out. Now, you can be chronically hypertensive and not have preeclampsia. That obviously needs to be managed. So if you've got someone who's got severe hypertension and a normal PlGF, it doesn't mean that they can be ignored. They still have to be managed as a chronic hypertensive. But it does mean they don't have this multisystem disorder with the perinatal risks, and you can completely change your management pathway. And the same goes with proteinuria. You know, you don't have to wait for proteinuria once you know the test is normal. If the test is abnormal, then you want a whole screen of tests, and the more downstream the better, to say, how bad is it? Is this woman going to need delivery soon, or can we wait? And you basically treat her as if she has preeclampsia. I hope that answers the question you were alluding to, Alice, but tell me if not. Or you're on mute. You're on mute.
There we go. So just one other question, Andy, if that's okay. Do we use the protocol to triage patients for inpatient versus outpatient care?
Yes, I mean, I think that if you look at how the protocols are, and I think the other speakers will probably allude to the management, but essentially, once you know the woman is, if she's got a normal PlGF, there is very little need for inpatient management, because her risks are of needing delivery in the coming weeks and even months are incredibly low. So yes, it can be very nicely used to triage for inpatient and outpatient management. You know, if there are other processes going on, why she's come in with a suspected disease, if she has underlying diabetes or she has chronic hypertension, those obviously have to be managed separately. But for ruling out a pre-eclamptic test and all the associated risk with pre-eclampsia, this is really useful.
Great, thank you very much, Professor Shennan. So we'll leave it there for questions for now, but we can come back to other questions at the end when we'll have a longer time for questions.
And I'm sure, Alice, those are questions are going to be answered by the next speakers, because they're the kind of management ones. I was just giving an introduction of the need, and we can answer those questions later. Thank you.
Exactly, great, thank you.
Thank you so much, Andy. So sorry, thank you, Alice. Who is the trial coordinator of PARROT-2 trial, and we'll hear more from her later. Without further ado, I'd like to introduce Professor Jenny Miles from Manchester, who's going to talk to us more about the SFLIC PLGF ratio. Over to you, Jenny.
Hello, good afternoon, everybody. Can you just thumbs up, Louise, if everyone could? Yeah, brilliant. Okay.
Oh, so, good.
So good afternoon. So I'm just going to quickly talk about PlGF-based testing during COVID and our experience of using the Roche test up in the northwest. Just a couple of disclosures. I've done research with both Quidel and Roche on both platforms. I contributed to the NICE guidelines, which recommended diagnostic testing using these biomarkers, and I've been helping implementation across the Northwest, and I'm also delighted to be a co-investigator of the PARROT-2 study. And today, just over the next 15 minutes, I've been asked to talk a little bit about the Roche test, a little bit about PlGF-based testing for FGR and stillbirth, multiple pregnancy, and a little bit about our experience in the Northwest during COVID. So Andy's already very helpfully been through this, and just to remind you all that we know that in women who've got preeclampsia, the level of soluble FLT is very significantly increased, and the level of placental growth factor is very significantly diminished. And you can either measure those analytes separately, or you can express them as a ratio. And as Andy's just told us, those are reasonably equivalent. And we know that there is a link from understanding the pathophysiology and the biology of this condition, that high levels of soluble FLT and low levels of placental growth factor are what contribute to the vascular endothelial disease that Andy's just been telling us about. So in terms of measuring those levels, the first kind of big study which demonstrated the clinical utility of measuring those markers was the prognosis study, which specifically used the Roche platform. And that was done a similar time to when we did the Pelican study, which measured PLGF alone, which I think Lucy will mention in a moment. But this basically used a cohort of 500 women to work out what the threshold for the ratio test should be, and then they validated that in a second cohort. And what they showed was that there was a very good rule out, so the negative predictive value was very high. So if you had a normal ratio less than 38, the likelihood of developing preeclampsia in the next 7 days was very, very low, less than 1%. Sensitivity and specificity were also very good. And also in terms of rule in, so the likelihood of developing preeclampsia within the next 4 weeks, if you had a positive test, you can again see the sensitivity and specificities there. So this was shown to be, in this study, a very useful test. And since that was published, there have been lots and lots of other publications which have shown very similar sensitivities and specificities. Very relevant for us in the UK was a study that Manu Vatish and colleagues did in Oxford, which looked to investigate how this test would alter clinical management for women presenting with signs or symptoms which would be suggestive of preeclampsia. And in the INSPIRE study, they randomized women to having the test revealed to the clinician or performing the test but not revealing the test to the clinician. They had 370 women, and the overall preeclampsia rate in this study was around 1 in 4. And what they showed in this study, in very similar way to the PARROT study, which was a similar concealed revealed test that we did with the PlGF test, that the time it took to make a clinical diagnosis was significantly shorter when you use the test. But really interestingly, in terms of clinical care, this study showed that although there wasn't a significant difference in the number of women who were admitted overall over the time course of the revealed versus concealed comparison, the number of women who were admitted who had a diagnosis of preeclampsia was significantly higher in those women where the test had been revealed to the clinician. But perhaps even more importantly than that, amongst the women that were admitted, the prevalence of adverse pregnancy outcomes was much higher, demonstrating that we had the right women in hospital informed by the use of the test. Manu and his team also compared the sensitivity, specificity, NPV and PPV, comparing standard clinical management, which is SCM, versus standard clinical management enhanced by the ratio, or in fact the ratio on its own. And you can see that we're pretty good as clinicians, and we've known that for a long time, that we're able to make a diagnosis of preeclampsia. But you can see that when we use the ratio in addition to that standard clinical management, the accuracy of that diagnosis is likely to be much improved. So quickly, some of the literature around the use of angiogenic markers in other placental diseases, and we know that the overlap between fetal growth restriction and preeclampsia is significant, and there are some women who develop growth restriction without hypertension. There are some women who develop both, and then there are a group of women who develop hypertension and other signs of preeclampsia who don't necessarily have objective evidence of fetal growth restriction, and that continuum has always been pretty difficult to tease apart. Now, I've had to just cherry pick a couple of studies here, so if I haven't shown your favourite study, then do bear with me, but just a couple of example studies from the literature. So this is a study that was led by Melanie Griffin with Lucy and Andy and several other of us across the UK, where we recruited nearly 600 women who were considered to be at risk of small for gestational age and were referred to secondary care for a growth scan. And this population was significantly enriched for babies born under the 3rd centile and babies born under the 10th centile. Lots of numbers on this table, but the summary of this is that placental growth factor modestly improved the sensitivity and specificity for detection of small for gestational age babies as judged by a customized centile, but there wasn't a very significant improvement in this. And interesting to say that only about 10% of the women with small babies in this study developed preeclampsia, and there is definitely in my mind an emerging story around the distinction between normotensive SGA and hypertensive SGA and the utility of these biomarkers in those two conditions, which often are quite difficult to disentangle. This was a study by Gordon Smith's group, which looked at the utility of adding a soluble FLIP PlGF ratio to a growth scan at 28 weeks and a growth scan at 36 weeks, and basically demonstrated again slightly improved performance of a screen if you add this biochemical marker at the time of that assessment, and certainly improves the specificity of the scan and therefore allows perhaps the right women to be identified as needing further intervention. Again, in terms of cherry picking studies, this is another interesting study which specifically investigated the use of the ratio test, the FLIP PlGF ratio, in identifying adverse fetal outcomes specifically. And this study showed that there was a very high sensitivity and specificity for identifying those women who were going to go on to develop an adverse fetal outcome, which was a composite there you can see at the bottom. The vast majority of that composite was made up by early deliveries and by small babies, as you might imagine. What was also interesting in this study is that there were 10 women who had a ratio above 400 in this study, which is obviously a very significantly elevated ratio, who didn't meet a clinical diagnosis of preeclampsia, but did have a significant adverse fetal event, almost certainly related to placental disease, demonstrating that there are a group of women who develop very significant consequences which are reflected in fetal outcomes rather than maternal outcomes. We don't have any studies which allow us to look at the diagnostic accuracy for stillbirth, but we do have some observations from some of the cohorts. And again, I've just cherry-picked a couple of headlines here. The Pelican study, which looked at PLGF alone, demonstrated that the 7 antepartum stillbirths that happened before 35 weeks in that study all had low levels of placental growth factor. But a couple of cautions in relation to stillbirth. We had 2 cases of stillbirth in our high-risk clinical evaluation study, which did not have abnormal levels of placental growth factor. They were norm-attentive SGA stillbirths. And in the case series I'm going to show you in a moment, which is our recent experience, we've had a number of babies that are small for gestational age, some of them with very abnormal Dopplers, that have normal angiogenic biomarkers, and those women have remained completely norm-attentive throughout, suggesting there are a group of babies that have a very different pathophysiology. And Andy Sharp and Alex Heasel and colleagues are currently performing a study looking at the relationship of these angiogenic markers, the ratio test, in babies at risk of fetal growth restriction and poor outcomes at term. So we'll await the results of that study. Very quickly, I was asked to touch on twin pregnancies. Because there's an increased volume of placental tissue in twin pregnancies, it's reasonable to hypothesize that there will be higher levels of soluble FLT, and that is indeed true. This is a study by Suresh Rana and Anand Karamanchi, who are the team who've done an enormous amount of work in this area. And they showed that in twin pregnancies complicated by preeclampsia, if you look in the middle column there, soluble FLT levels were higher and PLGF levels were pretty similar to norm-attentive controls. But the ratio did seem to be different in pregnancies complicated by preeclampsia, even in the setting of twin pregnancies. This study by Stefan Valoren's group, if you look at the left-hand panel there, you can see that levels of soluble FLT were higher in twin pregnancies in those women with preeclampsia. PLGF levels were lower, and the ratio again was higher, pretty consistent with what we see in singleton pregnancies. And the right-hand panel there shows the comparison of soluble FLT in twin pregnancies compared to singleton pregnancies, and you can see pretty comparable levels of soluble FLT and PLGF and of the ratio. But a word of caution here: we don't have a prospective large study in twin pregnancies looking at the clinical utility and the safety of applying the ratio. Some of the studies in the literature have demonstrated we should be adjusting the ratio, but none of them have been tested with the kind of numbers that we'd need to really look at normal outcomes or adverse outcomes. So we need to be very cautious. I think personally, having used the ratio in lots of twin pregnancies, I think it does have some utility, but you have to be very careful about what it's telling you in context of the whole clinical context. So quickly then, a little bit about what's been happening in the Northwest over the last year or so, since we've been implemented the ratio testing, which was funded by NHS England over the last year, and whole hospitals across England have been able to implement PlGF-based testing funded by NHS England. And the AHSNs have been very supportive in terms of implementing the test, and there are many regions across the UK, across England now, who are using the test as a result of this programme, which has been very successful in my view. So across Greater Manchester and East Cheshire, we have about 37,000 births per annum. And this is some very hot off the press numbers that I'm very grateful to Joy Stonebanks at Health Innovation Manchester for producing, which basically summarises where we're up in terms of testing. And all of the hospitals across Greater Manchester and East Cheshire are now up and running using either the Roche platform or the Quidel platform. And you can see in the far right-hand column there, the kind of frequency of testing rates, and that's just as a crude percentage of the number of births per annum in each hospital. And you can see there's some variation there. And we thought it was important to look at that across the region to do some benchmarking in terms of people may not be testing as many women as they could be. And in fact, some units may be testing more women than need to be tested. And that's important from a cost utility analysis. So probably somewhere between 5 and 8% is about right, we think. And so some units could do more, some units perhaps a little bit less. I'm afraid the rest of the data I've got is really only related to St Mary's Hospital, Manchester Foundation Trust, because that's where I've got detailed data from at the moment. So in Manchester, we started testing in September 19 under the NHS England funded programme. We've done 900 tests to date, and I've got a little bit of data on 445 tests which were done in 317 women. And you can see that 28 tests were done in twin pregnancies, of which that was 17 women. And it does look like we've had a bit of an upturn in the number of tests that we've done towards in the spring of this year, which everyone will remember obviously coincides with the beginning of the COVID pandemic. And we had a very focused effort at MFT to try and use the test as much as possible to try and keep women who did not need to be in hospital out of hospital. And clearly that is one of the huge advantages of using the test, is that it identifies those women who are at most risk of adverse outcomes and therefore most needed to be in hospital. As you might expect, the test was mainly done in the antenatal clinics. The 5th floor there is the specialist antenatal clinics, which see a lot of high-risk women with hypertension, diabetes and growth restriction, and other tests done either in triage or on the day unit, as you would expect, with a few done while women had already been admitted. Looking at admissions at a very high level, most of the women who had an abnormal test, shown in the red bars there, were admitted to hospital. But the important number really is that 88% of those women with a normal test were not admitted to hospital. And clearly that's a very important metric in terms of making sure that the test is doing what it's supposed to be doing, which is reassuring women and clinicians that this woman is not going to develop an adverse outcome in the next 7 to 14 days and therefore can be safely discharged from hospital. The bottom panel there does highlight, and Andy mentioned this, that some women, even though they've got a normal PlGF test, will need to come into hospital for monitoring for another reason. That might be to monitor their diabetes or their blood pressure because they've got chronic hypertension, or they may have reduced fetal movements. There are other reasons, and it's important to capture that in my view, because it does alter the admission metrics that are reported in relation to the test. In terms of surveillance, whether the admission was appropriate or not, we've made a kind of subjective assessment of, and I should say that Emma Tomlinson, who's the midwife who's been working on this data set, has done an absolutely fantastic job of collating this data, and she's worked through what should be happening in terms of the agreed pathway and compared that to what actually happened to look at whether we are admitting women appropriately and whether their outpatient surveillance is appropriate, so they're not being brought back for unnecessary visits once they've got a normal test. So it would seem that we're doing pretty well on that. I'll scoot past this, I think, but this just to show that there is obviously a big variation in terms of the number of days from test to delivery. But as we would expect, those women who have an abnormal test, which is shown by the red dots here, are likely to be delivered and need delivery because of adverse events in much sooner than those women who have a normal test, shown by the blue dots. And lastly, just again, some very crude perhaps numbers in terms of our test performance. Looking at a clinical diagnosis of preeclampsia, this has been what's been documented by clinicians that Emma's been able to extract from the digital care records. And I guess if you just look at the last column here on the right hand side, so this is a test done within 14 days of birth, 128 women, and you can see that sensitivity, specificity are reasonably as we would expect, and high positive predictive value and a high negative predictive value. So in our hands, this ratio test is, I don't know what I would do without it now in terms of being able to triage care. It makes a huge difference to the women and a huge difference to our confidence in how we manage these women. But I think it's also very important to say that no biochemical test is a certainty. And in the time frame that I've looked at this data, there were 2 very definite false negative results in women who had all of the clinical features of pre-eclampsia and therefore needed to be managed as if they had pre-eclampsia despite a normal test. So I think we always need to make sure we are evaluating women thoroughly and using this as an adjunct to our clinical diagnosis rather than a replacement of our clinical acumen. So I'll stop there, but a huge thank you to Emma, particularly for collating the data I've just shown you, and to Natalie, who's helped with that, and all of the team in Manchester, particularly my colleagues at Health Innovation Manchester, who've worked so hard to get this test up and running across the Northwest. Thanks.
Thank you so much, Jenny. If I could, we're not going to have questions right now. What we'll do is hear from our next speaker and then have questions at the end. Could I ask everybody to please pose their questions in the question and answer box so that we can collate them all in one place rather than putting them in the chat? That would be really appreciated. Thanks. So now we'll move on to hear more about the Quidel platform from Professor Lucy Chappell. Over to you, Lucy.
You're on mute, Lucy.
Thanks. I'm just sorting out my slideshow. And I hope you can all see that. Lovely. So I'm going to give you a bit of background about the Quidel test and talk about a number of the areas that Jenny and Andy haven't covered. And then after this, I'd like to widen the discussion about implementation a little bit more through a panel discussion. So if you think about a really cornerstone of our antenatal care is blood pressure checks. And quite rightly so, and it doesn't matter where we are. That's what we do around the world. But I'm suggesting that the PlGF test has really changed one of the fundamental parts of our antenatal care. And that's really been through this understanding. I like this image from this paper, which really sums up both what happens in the first half of pregnancy, what the clinical manifestations are, and where soluble FLIT and PlGF are really the link, one of the crucial links between these 2 stages. I like sort of going back to sort of the story, and the reason is that I want to get across that this isn't just a flash in the pan. Andy mentioned that this is the end of a very long pathway. Some of you will know the off-quoted statistic that it takes 17 years for a test to get from bench to bedside, and we really are on that pipeline. This is one of the very first references I can find in 1998 showing that placental growth factor concentrations were low in women with established pre-eclampsia. And Andy mentioned the work I did back in 2002 in the late 1990s. And we took this test through the proper routes. We didn't just say at that point that it looks good. We went through the cohort study, the Pelican study, which many people on this call contributed to, showing that placental growth factor was better than currently used assessments, so blood pressure, to determine who was going to get preeclampsia. And importantly, introduce this idea that placental growth factor could stratify, could pull apart the women, showing that in women under 35 weeks, you could split it into those with a very low result who had a median of 9 days to delivery, those in the intermediate amber group who had a median of 21 days to delivery, and then this group who are normal, who are going 7-8 weeks until delivery. And that's very much borne out by what Jenny's just been talking about. So again, although many of the tests that we use in the maternity care and in wider medical care have never been through a trial to assess whether they are good, and the trial of a diagnostic test broadly has a number of components. does the test perform well? So is it a good diagnostic test? We had showed that it was a good diagnostic test in our Pelican study, but was that borne out by the trial? Then you have to ask, do clinicians and women do anything differently as a result of your diagnostic test result? So when we stratify into those groups, does anything change? And then the third component is, does it make any difference to downstream clinical outcomes? Remembering that you might just say, well, diagnostic tests should be good at diagnosing. But if you really want to make a difference to care, you want to see both the diagnostic test and clinician action and women acting differently, such that it makes a difference to downstream clinical outcomes. And I would ask you to think about whether or not you think that many of the tests that we've used in obstetrics have been subject to this level of scrutiny, and the answer is, broadly speaking, no. So the triage result you can get in 15 minutes. This is an image of it, as you've heard. And these are the guidelines that we used. And I get a few queries about this because we started with quite a much more complicated one. And I know that there are more complicated algorithms. So the top half of this is the old NICE guidelines that were in use at the time of the Parrot. And we went round about what level of guidance should we give. And it started off with more boxes and arrows. And I know that there are a few. There are pros and cons. You can either be highly specify what pathway people should follow, or you can take the view that placental growth factor is one piece of the jigsaw that should be integrated into all the blood tests, potentially into urinary results, growth scans, and that you then do what we do every day is make decisions as a clinician with the overall picture. And I think there's a place for both. But if you think about what Andy and Jenny have both mentioned, which is that if that woman has a very small symphysis fundal height and you are concerned about the growth, then of course you would organise a growth scan. If she's got severe hypertension, then of course you would treat hypertension. So it is to be integrated into your bigger clinical assessment, but that this test is likely to be far more informative than the other blood tests that we commonly use. We know that the test performance of those is much lower than a placental growth factor. And I'm very happy to come on to this point in the discussion. So what did we find in the Parrot trial? We found that use of the test, reveal testing, reduced roughly half the time to make a diagnosis. It performed well as a diagnostic test, which is the point I made in the earlier slide. And interestingly, it reduced adverse maternal outcomes from 5.4% to 3.8%. And when we delved into this, it looked as if in the you can see that it reduced a number of these outcomes around eclampsia, stroke, cardiac arrest, which was 0 in the revealed group. Alongside that, we did a cost effectiveness analysis, and this is where it's important in terms of business cases that you all might be making to your units. So using real world data rather than previous papers that we and others have published on which used model data, we showed that clinical care with placental growth factor testing had a cost saving of around 149 per patient tested. And our results were very similar to the INSPIRE trial led by Manu Vatish at Oxford, which showed that it appears to get the right women admitted. So that stratification of care reduces unnecessary repeat visits, particularly for the women in the normal group, but you get more of the higher risk women admitted. So it's reallocating care to those who need it. And that's a really core component of our maternity care. We want safe maternity care. So just reducing admissions isn't necessarily our aim. We just want to get the right women admitted. And that's actually a very strong message from our public and patient involvement. So work published today, which is always nice when that coincides, is that one of the reasons we think we might have seen an impact is that this intermediate risk women, so those are the women, I would argue that sometimes we can all pick the women who are normal and we can put care back to normal. We might also be able to pick the women who are overtly at high risk. But there is this intermediate group which might not flag to us as clinicians. And one of the interesting findings in this, when we teased out the results from the Parrot trial, is that we saw a reduction in the adverse outcomes, particularly in this intermediate group. So I think of that as with these women coming onto your radar, maybe when you're a bit surprised when the placental growth factor comes back at less than 100, and you think, oh, maybe I do need to have her on my radar, because that was the group where we saw a significant reduction, particularly in maternal adverse outcomes. So how has it gone? Well, the Parrot trial was published on 1st of April, as it happens, last year, and there was it caught the imagination of the media, and I've learned not to underestimate that. I think it's because we were supposed to have Brexit the previous Friday, which got stalled, and I think they wanted something other than Brexit. But I don't mind, because putting pregnancy and pre-eclampsia into the public domain and into the media domain is always good. Thank you very much to Lauren, who's a woman who Jenny Myers has cared for, who came onto BBC Breakfast, and we had enormous reach from this, and that, alongside the NICE guidance, all collided to really push the message that it was time for antenatal care to change. And the support from the ITP payment, which many of you in England will know about, and the Accelerated Access Collaborative, has really been helpful in saying that it's time for this to go into the NHS. So this is an updated version of our algorithm, and we've stuck to the broad concept. This is the new NICE guidance on top, and that the 3 levels, and just trying to give a bit of information about what does it mean for these 3 levels. I would point out that we are taking a test which has got a continuous range. So the PlGF test goes from less than 12 to over 3,000. And although broadly we've gone into categories, you can use it as a number. So is there any difference between somebody with a PlGF of 99 and 101 picograms per mil? Broadly, no. But for the purpose of sort of giving some guidance, a little bit like platelets, we all look at platelet count in pre-eclampsia a bit differently if it's over 100 or less than 100. And you can think of placental growth factor similarly. So it is categorized for the purposes of sort of directing care, but just as you would with any other blood test, think of it but more as a continuous scale. And we're very happy to share this algorithm with people. So I'm going to mention how it works in established preeclampsia. These are data not published, but these are data from the Peacock study. This is women who took part in the Phoenix trial, late preterm preeclampsia. So this is the women between 34 and 37 weeks. And these are data which we've just got, showing that the test performs much less well in determining who needs delivery. And the main reason for this is related to a number of factors, is that 95% of women in the Phoenix trial had a placental growth factor that was low or very low. So your tests perform differently if you have a different distribution of the blood test, and which is one of the results, and that's one component of it. And the other component is that what drives delivery for preeclampsia, the placental growth factor may not be the best test to predict that. So I come back to the point that the blood test is for use in women with suspected preeclampsia, which is exactly how NICE directs it. It is not a test for women with confirmed preeclampsia, and we, as a community, we all need to be clear about how we are advising its use. So should you repeat the test? We've got to remember that the Parrot trial, the clinical and cost effectiveness was based on a single test. And NICE has been very clear that there is no NICE indicated repeat testing. This is it points it out as a recommendation for future research. So at this point in time, we don't have enough evidence to support clinical or cost effectiveness of repeat PlGF testing. And why is this important? It's because if we go to our business managers, we can say that a single test is mandated by NICE and is supported by the cost effectiveness analysis. But before we all blow our maternity budgets on repeat testing, we should stop and pause and say, is repeat testing indicated? And I think that's really important to keep our business managers on side so that we make the case, and that's on the basis of the initial test. So we have got some proof of concept data. This is data published earlier this year to show that the test performance is probably similar. And these are, just to sort of highlight, this is, if you look at the graph here, you can see the first block is the initial test. So when a woman tests initially green, about 75% will stay green on repeat tests. This is not trial data, this is from case series. But about a quarter will go amber or a small proportion red. And it won't surprise you that the women who go amber into the amber or red zones under 100 tend to be the women at the lower end of the green zone, which reminds you of the point about this is a continuous measure. Interestingly, even women who test with less than 12, because placental growth factor is a dynamic biomarker, about a quarter go into the amber zone, but broadly speaking, the recommendations for women in the amber or red zone are similar. So what do we need? We need PARROT-2. PARROT-2 is the trial that looks at repeat testing, revealed versus concealed, very similar. And this is the way we will get a robust answer on the clinical effectiveness and the cost effectiveness of repeat placental growth factor testing, which either means it will go into national guidance, or we will look at it again and really hold back on doing multiple repeat tests, which I think is important for the women and important for us as a community. So this has been a piece of work which many, many people have contributed to, not least the women, the midwives, and so many research fellows and others. So thank you very much to those. We had the opportunity to tell the story, as Louise mentioned at the beginning, in our BMJ Awards, which was shortlisted and got highly commended, and put with a video put together by Katie Kurt, which we've had very positive feedback on how a number of people have been using it for teaching, for talking with patient groups. So thank you very much to everyone who's contributed to that. I'd like to come on in the discussion about some implementation issues. Jenny mentioned the AHSNs, who have been doing an enormous piece of work to support this. And I know from talking to lots of people that there are more queries over that, and I think that best done through a panel discussion. Thank you very much.
So thank you so much, Lucy, and thank you to all the speakers. That's been really fantastic, and lots of interest and questions on the Q&A. So thank you for that. First of all, if you'd like to each share, Jenny's already discussed a little bit in Manchester, so perhaps Lucy, if you'd like to start at St Thomas's, some of the challenges to implementing PlGF-based testing and overcoming them.
Thank you. So I think it's interesting about how we in maternity care do adopt new innovations, and it's sort of, there's many levels that we could think about this, both at the system level and at the individual trust level. I would say a couple of really big challenges have been both the business manager, you know, the challenges that we've all had with that, and also at the laboratory level, whether we're implementing the Roche or the Quidel test. There is no one size fits all to this, and I think that one of the questions we have to ask is that when we have a nice approved test, why do we then have to go through so many hurdles? But that's where we are with bureaucracy. I think we have used the support from the HSN. We have chipped away at those, but talking to many sites around the country, it has come down to that work from an engaged, enthusiastic, usually consultant obstetrician with support from the HSN to say this is what the women deserve, and it's mandated by NICE, and how do we make it happen? The fact that we've got cost effectiveness showing 149 per woman, it's not. It suggests that that's a sort of simple answer and we can just go to the business managers and show that. And I know that people like Manu Vatish has done so much work in trying to think about how we communicate. And I don't know whether Jenny wants to come on about how we make that case.
Alice, do you want me to come in?
Yep.
Yeah, so I agree with everything Lucy's just said. I mean, you need someone to champion it, and someone, the hospitals where it's working well, the thing that they all have in common is that someone in the hospital has really taken the bit between the teeth and run with it. And there are two really important messages, I think, for the business managers. Is one, this is not going to cost you extra money. So the business managers get very upset about things being cash releasing or not being cash releasing. We've shown now in several different ways that this is a cost neutral. At worst, it's cost neutral. At most likely, it's cost saving. So it's not going to cost you more money, but we are going to have to reshuffle the way that we spend the money within the division. And so that's the first important message. The second, probably more important message, is that this is about safe maternity care. And it's about getting the right women into hospital and getting the right women monitored and the right babies born at the right time. And you know, stories there are several stories being gathered together through the AHSNs. Everybody who's used the test in clinical practice will very quickly be able to come up with a story of a woman who has positively benefited and where an adverse event has been avoided by using the test. So safety and quality should be at the forefront of all those discussions with the business managers. This is not going to cost them more money, just got to reshuffle, and it's going to save babies' lives and stop women having horrible adverse events. And that's what we have to get the message out there. And then there are lots of other barriers to overcome. I'm not saying for a moment it's straightforward, but it's doable. And the number of hospitals who've got it up and running have demonstrated that it's doable.
I'm just going to make one point about the validation. So we know that it has been challenging to get some of the lab validations done. And I don't have a straightforward answer to this. It's partly because the Quidel test is point of care. We have many centres that have implemented without doing additional validations by sharing I didn't know about 5x5 verifications before I started this, but by sharing ours, showing that the test is performing well. And it is a challenge in some sites. Keep talking to us, we will help wherever we can. We think that it is a bit surprising that you're being asked to collect pooled plasma and redo the test in every single unit, 170 maternity units around the country. So I'm not the expert on lab verification, but as I say, if I can share that there are plenty of labs and plenty of centres that are implementing without that requirement, it seems surprising that there is such a variance of lab practice around the country from that perspective.
Yeah, I agree. And you know, we've not necessarily talked so much today about the nitty-gritty specifics of the different platforms, but the point is that there are, you know, two options at the moment, and those options have pros and cons, and there are lots of people around the country who have got a good understanding of what the advantages and disadvantages of the platforms might be in terms of the practical implementation aspects. And so there's lots of people who understand how to overcome those barriers in terms of whether it's a point of care or whether it's being done in a central lab. In the Northwest, for example, we have a central lab that runs tests for 4 other sites. And so that's been a really useful collaboration. The same thing happens in Oxford. So there are ways of working around it and getting the test to your women.
Alice, whilst we're on the subject, shall I answer some of the questions about turnaround times?
Yes, I was about to pose those, yeah. Okay,
so turnaround time depends a bit on your setup and how you set it up. So for Quidel, it is you saw it on my slide, you take an EDTA, you spin, and it's a 15-minute turnaround from when you put it into the meter, which is so big, and get a result. So there is that extra time that we all know exists between getting the blood from the woman to the place where it is going to be centrifuged and tested, and then getting the result back. So broadly, when I see somebody in clinic, and if I want, I might do them I run a clinic for women with chronic hypertension, and on a Wednesday afternoon, it's a regular challenge as to whether this woman has preeclampsia, so she's got suspected preeclampsia, and I estimate that I can get a result in about 45 minutes, 60 minutes maybe, from me saying I'd like a PlGF to me having the result in my hand, because that allows for that. That is considerably faster than I can get a PCR. So PCRs are quite variable around the country. I have plenty of units. So our standard PCR turnaround is 3 days. Our urgent PCR turnaround is about 4 to 6 hours. There are units that are quicker than this, but I do not do PlGF-based testing. I don't do PCR followed by PlGF. I generally do them in parallel, and every time PlGF comes back faster than my PCR, without any doubt. But the other point is that I'm putting it into the jigsaw. So I would suggest, if you have a woman with suspected preeclampsia, and there was a query about what is suspected preeclampsia, it's easier to say what it isn't. If you have a woman who has got documented hypertension and a documented PCR of a level that you consider to be preeclampsia, then she has preeclampsia. You will note that in the NICE 2019 guidelines, we introduced the idea that if you have a single PCR of 31, I don't necessarily think that that is confirmed preeclampsia. In fact, I often don't, because if you retest, she may come back at 24 and you may undo your diagnosis. So when you as a clinician have firmly made the diagnosis of confirmed preeclampsia, then not. But for the women who have gestational hypertension, other signs and symptoms of uncertainty, then that's the women who need. So when you do those bloods that say query preeclampsia, that's when we're sending off our PlGF. I get a result in 45 to 60 minutes. Jenny, turnaround for the Roche test, what's that like?
So turnaround now in our labs for our site is a few hours usually. So within 4 hours now we get our test back on the Roche platform. Obviously it depends. We're running, as I said before, we're running the test in our labs for other sites. So that relies on the sample coming from another hospital to our lab, and then the result coming back again. So that's usually reported same day. If it comes to the lab late in the day, it won't be reported till the next day. So you can use the test even if you've got a longer turnaround time, and we showed that when we did our initial implementation studies. We weren't getting the report. They were just our lab were running them as a batch once a day for cost efficiency, and even in that situation you can manage women still very effectively by assessing their clinical need and deciding whether there are any parameters which require immediate admission, and if there aren't, letting that woman home and then reviewing the test the next day, as long as there's a good system in place for chasing up the results, as you would with any other blood tests or PCR results, just in the same way that you would do now. So even when we were using it with a next day result, we were still reducing our admissions significantly.
So related to that, Joe Bailey has asked about agreed laboratory turnaround times. And I think that's a really good point, Joe, because and again, it depends whether you're doing it through a research lab setting or a clinical lab setting. And I think that needs to be put in place. I don't think there's a single answer, because it relates to whether it comes from another site, what your timing is from taking the blood, but to that viewable result. But I think those are definitely the questions that you should be talking to your laboratory about. Alice, yeah, Andy.
There's a question I've picked up there, which I think is quite important. It's asking that in a centre that already uses outpatient management for the majority of preeclampsia, do you think has added value in implementing PlGF testing? Absolutely, because the test is just not about do you come into hospital or not. It's about risk stratification. In other words, if you're abnormal, you basically treat as preeclampsia. And we know from the research that this is a good baby test and mother test. And I think I certainly get very nervous with a low PlGF for the baby, and it does direct the need for fetal assessment. And I think there's an onus then to watch the baby. Now, what I'd never do is deliver on the basis of an abnormal test, but it highlights the fact that this person needs to be under close observation. And being an inpatient doesn't mean you have everything, and being an outpatient you have nothing. You can still do most of your investigations, as you should do in established preeclampsia as an outpatient. This test will tell you when those women need those tests.
I think that's so important. This is about surveillance, stratification of care, and the way to think of it is it is better than all those other blood tests that you're doing, and it's had far more robust evaluation than all those other tests you're doing. So important.
Can I just come in there as well, that just to echo that point, that we've had case upon case upon case where on standard clinical assessments you perhaps wouldn't have been very worried about a lady, and as Lucy said in her talk, you know, the ratio test or the PlGF comes back as being abnormal, and it just means, crikey, that's someone we need to pay much closer attention to. And you know, we've not had in the last year in a woman with a very abnormal ratio test, even though some of those women have had very abnormal ratio tests and actually have not yet met the diagnostic criteria for preeclampsia. Not a single one, sadly, has let me down in terms of not developing an adverse outcome. All of those women will go on to develop an adverse outcome. And as Andy says, the abnormal test doesn't mean jump in and deliver. It just means watch like a hawk. And the duty is on us to have the conversation with the woman. We need to explain the risks to the woman. You've got a diagnosis of preeclampsia. This is the option. You could stay in hospital, or we could see you with very close outpatient surveillance with these risks. And I think the women need to then decide which they, you know, whether they would prefer inpatient surveillance or very close outpatient surveillance. But those women will, and you can't tell from the point of doing the test whether they're going to run into trouble the next day, or if it's going to be a week, or sometimes even 2 weeks, but they need watching like a hawk.
I've got another question, if it's okay to...
Yeah, I was going to say, what do you want us to take next? There's some really good questions here.
Yeah, great questions. Thank you, everyone. So in women with chronic hypertension on gently escalating treatment regimes, there may not be an obvious time to deploy a PlGF test. Given we just have one shot, unless we are participating in PARAC2, when do you recommend PlGF testing is most useful?
Can I just add to that? There's other questions within this that do relate to whether to use repeat testing. Obviously, we're hoping that we've answered. There isn't enough evidence yet. Please take part in PARAC2, but it would be really fantastic to hear your thoughts on this, guys.
Well, this keeps me busy on a Wednesday and Jenny busy on a Friday. It is a really interesting one, because if it is a one shot, Harry Gibson has captured it. Because I have a very high recruitment rate to PARAC2, I will offer it when I am first feel there is suspected preeclampsia. And the women are very engaged with the PARAC2 study because they get what the quandary is. Generally speaking, women are not the gatekeepers to take participation in research. Generally, it's us clinicians. So if we have a way of just saying this is what we're doing to get the answer, then the take-up rate is high. And I then have a 50-50 chance of having revealed versus concealed. So the first answer clearly is take part in PARAC2. We have Roche sites and Quidel sites, so we're open for business to anyone who's implemented. Other than that, it is when am I, this is down to clinician experience. And before I started the chronic hypertension, the clinic for women with chronic hypertension, we look after, as many clinicians on this call do, women with hypertension and proteinuria from 24 weeks, and we bite our nails until we get a baby out, hopefully many weeks later. So it is when that tips subtly to, you know, the PCR might have gone from 30 to 55, the blood pressure's inevitably gone up, but the bloods are normal. And when I want a bit more reassurance to manage her as an outpatient, that is when I'll do a PlGF. There is no single threshold of blood pressure or protein or anything else, but it is when I am concerned about the pattern, because preeclampsia is a syndrome. It is not a sort of, you know, single neat disease entity. Jenny, does that match your experience?
Yeah, absolutely. I mean, the same thing. It's really difficult to know, and that's, you know, it's a small group of women than women with chronic hypertension. But in terms of morbidity, both perinatal morbidity and maternal morbidity, they're a hugely important group, and timing interventions right in that population has always been very challenging, and it's made much better by having this biochemical test, because it means we can identify the group who are at most risk of developing adverse outcomes. But getting the timing right, as Lucy says, is a real challenge. on a Friday, we not uncommonly do 5, 6, 7 tests in women who've got chronic hypertension. We have a little huddle at the end of clinic, and we often say who we think is going to have an abnormal test and who hasn't. Sometimes we get it right, often we get it wrong, demonstrating that actually the test gives you that additional piece of information. So when you're worried, when you think that admission might be necessary, or you're thinking, gosh, do I need to be thinking about planning delivery early? That's the time to do the test, in my view. But I would echo what Lucy says. If you're implementing, get into Parrot 2, and then we can answer that question and start doing, being able to inform on that question properly.
Great, thank you, both of you. So next question, is there a cutoff you use for urine PCR when PlGF testing is not done? So with borderline, AG borderline results.
Andy, do you want to talk about that?
Yes, I mean the NICE guidelines are pretty succinct about proteinuria, and it now says do not rely on 24-hour specimens, do not do early mornings urines, and essentially you can use your PCR cutoff of 30. You know, if you have the borderline, you can repeat them. You know, I think proteinuria has had a lot of attention over the years as being a really key diagnostic sign, but it is just one of many, many other signs of the disease. And you know, if you have an abnormal PlGF and don't have proteinuria, you should be equally worried. So I would appeal to you saying, you know, we rely on proteinuria. Don't rely on proteinuria. Put your efforts in something better, and in this case you have something better.
Yeah, I would just again echo that. I was going to try and pull that data out today to show, but I didn't quite have time to share that actually a lot of women who have an abnormal ratio or a low PlGF won't actually develop proteinuria by the time you deliver them, but there's no doubt that they have pre-eclampsia on other metrics. So we've known for a long time that proteinuria is not that useful, and we now have a better test. And we still measure proteinuria, but we have got a better test. The other thing, in the Northwest guideline, our threshold is 30, in agreement with the NICE guidelines, but we have a line that just says if it's between 30 and 50, consider repeating it to confirm it's still between 30 and 50. And if it's above 50 on a single shot, then they've almost certainly got proteinuria. So that's how we use PCRs, but you know, we've got a better test now, so let's use that as well, or instead.
Some of the questions coming through are asking about using it outside the sort of current remit of suspected preeclampsia. That's a really big question. I think we would probably say, and I welcome what my panelists think, you know, don't use it outside the remit, i.e. don't use it as a routine screening test. All the research is based on its added value in a, you know, with a population was already a pretest probability of a problem. If you start then saying, oh, well, let's just screen everyone and or people without preeclampsia, we just don't know the value, and that is not a good thing to do yet. When we have looked at PlGF for other indications like IUGR, yes, there's an association, of course there is, but it's not good in terms of replacing ultrasound scan or doing anything like that. So just a warning about stepping outside the remit of the evidence.
There is work underway to look at placental growth factor as either part of the algorithm at 12 weeks or 20 weeks. And there is other published work that is being actively considered by the National Screening Committee to work out whether that should be introduced. And some of you are aware of that piece of sort of review. So I think for now, it's reasonable to concentrate on getting the NICE guidance into clinical practice, and then when the NICE or National Screening Committee come up with their next set of guidance, it has been through the mill and it has been deemed useful to introduce. So as Andy said, use it as it's indicated and NICE approved, because you know that there's a good body of evidence and there is work underway for exactly what you propose.
Yeah, I mean, I think I mentioned it in my talk. I think we've got good evidence that in the context of maternal hypertension, it works extremely well. There is a small group of women who have growth restriction that will not be identified by abnormal androgenic markers. And in my experience, that is women who have, and I'm not talking borderline blood pressure, I'm talking completely normal blood pressure. And so we must use it at the moment in the context for which we've got the good evidence.
Can I come on, Alice and Louise, to a couple of the repeat testing queries?
Yep.
So a number of questions about how it is used and interest. So we'll go back to nice guidances for a single test, and that it can be challenging to say, oh, shall I hold on a bit longer? But when you've got a woman with suspected pre-eclampsia, if you are sending query pre-eclampsia blood, so you can send a PlGF if it's in your centre. And Amy Hannington asks, how does it happen that it rises? Well, placental growth factor is produced by the placenta, as it says, and probably a couple of other areas. And the normal pattern of PlGF is that it rises typically up to 28 to 30 weeks and then typically falls, but in any individual woman you will see some variation. And I showed you in my screenshot that women can transition from one category to another, or you will see some variation in their placental growth factor. So it's not impossible that the result goes from 20 up to 50, for example. It is unusual if she's in later pregnancy to go from 20 up to 200 to 400, but the woman is producing placental growth factor, so that is biologically possible. However, typically you will see a fall in the third trimester, say beyond 30 to 32 weeks up to 36 weeks, and that is typically what will happen. We don't know the optimal frequency or indications for repeat testing, and that covers a couple of queries about how should we do repeat testing, and we are really clear that we don't know. So for example, if she has a normal result on either of the tests, should you repeat it every 2 weeks, every 4 weeks, or only when clinical symptoms reoccur? If she has an abnormal less than 5th centile, should we repeat it weekly, 2 weekly, or as clinical symptoms? And the only way we're going to get the answers to this is by doing the research. So I know we kind of go on about it, but if I knew what to do, we would have an algorithm that told us how to do it. And if we don't, then we go out and find it. So I think that covers a number of the questions about there is no clear guidance on when it should be repeated, and that's why let's get the answer together. Also related to that, Mel's talking about how late in pregnancy. So the NICE guidance is up to 35 weeks. I know a lot of people are using it up to, and certainly doing repeat testing up to 37 weeks. As Andy mentioned, its test performance beyond then is uncertain and not recommended.
Can I just come in, Alice, there's a question there about engaging with midwives doing the testing. Yeah, can I just come in on that? So we in the Northwest, we've worked quite hard to engage midwives, and one of the ways we've done that is by using kind of education buses, which is I don't know if that's a concept that everybody's using, but I don't know if it's St Mary's invented term, but where we go around with a trolley with some posters, maybe some sweets, and go around the units and just tell people who were on the ground that day, on the day unit, in clinic, on the labour ward, about this is the test, have you heard of it, have you got any questions, have you been using it? And we've done that a few times, both at our site and at Wythenshawe and at other sites around the Northwest, and that's been supported by people from the companies, from the platform that test was being, whichever platform was being used. And that's a really good way, I think, of just engaging the midwifery staff. And it absolutely is essential that the midwifery staff, the junior doctors and the consultants kind of buy in to understanding in whom and when to use the test and what its potential benefits are. So I hope that answers that question.
Thank you. So just more questions on implementation. There's been questions on the cost of the test, of an individual PlGF test, and also currently carrying out clinical audits to inform business cases for funding from April 2021. And are we aware of any published service evaluations?
So can I come in on that quickly? I'm sure Andy and Lucy will have things to say. So there are some various models around for the cost effectiveness model, but I think in my view, We've got published cost utility data from Parrot, which showed a cost saving. We've got Manu's data from Inspire. We know that this is a test which drives up safety and quality and is almost certainly cost saving, or at the very worst cost neutral. I've said in lots of meetings that I'm not sure that service evaluations, small level service evaluations, especially collected while people are on a learning curve, are necessarily going to be any better than the published data that we've got showing cost effectiveness, which is also was published as part of a NICE guidance. So I would urge us all to use the published data, and you then use the numbers of people within your unit about having the test done, that's fine, but use the published data to build the business models. And we need to be working together, and that's something we're doing across Greater Manchester, trying to produce one model that everyone can use. And I'm sure it's the same across other regions. I don't know if Andy or Lucy have got any other thoughts on that.
Andy, what do you think?
Yeah, I mean, I'm going to say the sort of obvious thing, which is that the clinical benefit and the value to the women is just so obvious that I think the minor debates around do you save a bit of money or is it cost neutral are pretty insignificant compared to the obvious benefit when you use it, and we as clinicians just need to get that message over to the people calling the shots here. I don't know if that's a sort of old school thing to say, but I think we have to do that.
And Lath has just asked, how do you bring the consultant colleagues on board? So one of the interesting things is that when you get it in, you win them over by showing them the test, and they all start asking for it. And I think that I've heard that from so many units. It's just the how do you get them in the first place? You show them the data, you show them the NICE guidance, you show them the cost effectiveness analysis, and sort of say, why wouldn't you want this test? I know that is easier said than done, but actually why wouldn't you implement a NICE diagnostic guidance which happens to be cost saving, and has got very strong support from the patient support group. Action on Preeclampsia have been very vocal in saying this is what women and their families want. So but I don't underestimate how hard it is sometimes to win people over. I know that we are getting close to the time, and I'm just going to say that the core team will answer your questions in the chat. I think we've covered a lot, but there's clearly sort of very wide interest. There's a couple of things about additional sort of business cases, and as I say, really for us, getting it into use as dictated by NICE guidance would be such a huge start. And before we go into the what next, it would be really good to get high uptake across NHS, across England, of where it is approved, and then it gets easier to say where else could we use it. So I know that's about reducing unwanted variance between units, because actually that's what our women and their families deserve. So if we all said let's get into practice what is there, I think that would be a really strong case. And then also, the step of let's also show that as a community we can embrace the uncertainty about repeat testing, but because look at what the Inspire trial and the Parrot trial, look at what happened as a result of that.
Can I maybe just add that if people have got practical, clinical, logistical questions about implementing testing, any of us here, and all the people already involved, myself, Manu, who's also acting as a clinical champion for implementation, Lucy and Andy, Alice and Louise, we're all very ready and willing to try and get as many units running as possible. So please do contact us by email. We're all very easy to find, and we'll try and point you in the right direction. Or contact your AHSNs, who will also be able to help with implementation.
I'd like to draw the session to a close and say thank you so much to everyone, and a final message to say get everyone involved, bring the consultants on board, make sure lots of the midwifery team, once they see the benefit, the juniors, everybody can become enthusiastic about this. So remember to use your broader team, and thank you so much for coming and joining us. Do get in touch if you'd like to join the Parrot 2 trial. Many thanks.
Thank you.